Hi guys, I hope I'm live and audible. Just give me a thumbs up if I'm visible to you, and we'll start with the questions. I hope all of you have given the test and you were able to do reasonably well. If you were stuck with any question, I'm here to address your doubts and queries. So just give me a thumbs up if I'm audible to you, all of you. Okay, so let's start with the questions. The exam is not very far, so let's not waste our time. We'll begin with the very first question. This is the question that you faced on your test. Here we have a 65-year-old patient who presented with dyspnea on exertion. The age of the person is 65. He is presented with dyspnea on exertion, orthopnea, bilateral lower limb edema. Examination, there is crackles at the lung basis and an elevated jugular venous pressure. Echo reveals an ejection fraction of 35. So with this picture, what is the diagnosis? The diagnosis from this picture we are thinking of is heart failure with reduced ejection fraction. जब EF less than 40% होता है तो we call it as heart failure with reduced ejection fraction. Which of the following medication is indicated for symptomatic relief and mortality reduction in this patient? So basically एक heart failure का question है. Heart failure में what all medications we use and how are we going to reduce their mortality? So when we are talking about heart failure, in heart failure there is increased activation of RAS and increased activation of natriuretic peptides, and we know that जो RAS activated है, it is harmful for a patient with heart failure. This RAS is harmful. जितना ज़्यादा एक्टिवेट होगा उतना ही वो हार्ट को हार्म करेगा. एंड natriuretic peptides are beneficial because they make, now already इस पेशेंट में बहुत सारा, this patient has got plenty of fluid retention, he has edema. So in such circumstances, if I am able to unburden the heart by reducing the edema and the fluid retention, it is helpful. So natriuretic peptides like ANP, BNP help me drain out fluid, but RAS with its aldosterone increases the sodium and water reabsorption. This is harmful, this is beneficial, I need to block it. So what all drugs I can use to block it? The drugs that I can use to block it include, I can block angiotensin 2 with AC inhibitors or ARBs. I can block aldosterone with spironolactone. Okay, and apart from RAS, I think I forgot to write down, we also have sympathetic nervous system activation, which is also harmful. The sympathetic nervous system that gets activated in heart failure is harmful. So this also needs to be blocked. So I should block that with the help of beta blockers. Beta blockers. So all these drugs are associated with mortality benefit. So these reducing the harmful impact on the heart, they reduce mortality. Similarly, on this side, the natriuretic peptides like ANP, BNP, once they are formed, these are the natriuretic peptides. Once they are formed, see, these are beneficial. More ANP, BNP is good for heart. But once these are formed, these are usually broken down to inactive peptides by an enzyme called neprilysin. Neprilysin. तो अगर मैं इस neprilysin को block करूँगा, if I block this neprilysin, I will have more ANP and more BNP, which will be highly useful for a patient with heart failure. So how do I block this? Neprilysin can be blocked by neprilysin inhibitors. Neprilysin inhibitors इसको block करेंगे. That includes a drug called sacubitril. Sacubitril. Sacubitril is also known to reduce cardiovascular mortality. This will also be associated with reduction in mortality. Apart from that, we have a new class of drugs which is primarily antidiabetics but reduce the cardiovascular mortality. They are also beneficial in patients with heart failure, that is SGLT2 inhibitors. तो ये सब mortality reduction करते हैं. What all drugs reduce mortality? AC inhibitors, ARBs, spironolactone, beta blockers, SGLT2 inhibitors, and neprilysin inhibitors. On the other hand, inotropic agents actually increase the mortality. Inotropic agents like milrinone or digoxin, they are associated with increased mortality. digoxin and milrinone. These are inotropic agents. They are associated with increased mortality. So in this question, what examiner is asking, which drugs are associated, or which of the following drug we can give for reducing the mortality risk, death risk. They're asking mortality reduction. Which drug can give that mortality benefit? Digoxin, as I just told you, is associated with increased mortality. Milrinone is associated with increased mortality. Nifedipine, no role in management of heart failure. Carvedilol is a beta blocker, and we just learned that beta blockers are associated with reduced mortality. So we should be choosing beta blockers as the right answer here. Beta blockers are associated with decreased mortality. So carvedilol would be the correct answer for this question. Now we'll go to the next question. So here they are asking, in patient with heart failure, which of the following is a key feature distinguishing heart failure with reduced ejection fraction from heart failure with preserved ejection fraction? EF more than 50%, elevated BNP levels predominantly affects younger patients, or response to loop diuretics. Heart failure with reduced ejection fraction, how is it separated from heart failure with preserved ejection fraction? Okay, heart failure with preserved ejection fraction is associated with EF more than 50%. Heart failure with reduced ejection fraction is associated with EF less than 40%. So if EF was less than 40%, it is heart failure with reduced. So this statement doesn't fit into this. Which of the following is a key feature distinguishing heart failure with reduced from preserved? Elevated BNP levels are seen in both. Elevated BNP levels are seen in both. Predominantly affects younger patient. Response to loop diuretics. Response to loop diuretics is seen in both. Okay, so what I would say is this question is not well constructed, to be very frank, because if they're asking which of the following is a key feature distinguishing heart failure with reduced and preserved, if the answer has to be option C, then the way the question should be framed is which of the following separates, or which of the following feature is not encountered in patients with heart failure with reduced ejection fraction, or not encountered in patients with heart failure with preserved ejection fraction. Or they should have framed it as which of the following is not which of the following statement is not consistent with the diagnosis of heart failure with reduced ejection fraction, or not consistent with heart failure with preserved ejection fraction. The question is a bit bland, and right now I would prefer to stick to option A as the answer, because heart failure with preserved ejection fraction, you have more than 50% EF. Heart failure with reduced ejection fraction, you have EF less than 40%. If the question was framed in a way that which of the following is more in favor of heart failure with preserved ejection fraction, this statement will be one. Second statement will be it predominantly affects younger patient, because the most common cause for heart failure with reduced ejection fraction is ischemic heart disease. Heart failure with preserved ejection fraction is hypertension. So not a well constructed question. I hope you have made an attempt at least trying to apply whatever you know. Now let us quickly revise heart failure classification. Heart failure classification. So heart failure will be divided into heart failure with reduced preserved ejection fraction. This is when you have EF more than 50%. Normal ejection fraction is 60 to 70%. If you have heart failure with ejection fraction more than 50, it's still fair, so it is close to normal, so we'll consider it as heart failure with preserved ejection fraction. EF more than or equal to 50%, and it is heart failure with preserved ejection fraction. The most common cause for it is hypertension. It relatively, like if I'm seeing patients of heart failure, then hypertensive heart failure usually occurs in relatively younger individuals. Ischemic heart failure occurs in relatively older individuals, because you need to have multiple episodes of ischemia and infarction for your heart to fail significantly. Heart failure with reduced ejection fraction refers to EF less than 40%. The most common cause for heart failure with reduced ejection fraction is going to be ischemic heart disease. And when there is reduction in the ejection fraction, the force of contraction of the heart is reduced. So you can call this as systolic heart failure. And in heart failure with preserved ejection fraction, the force of contraction is good. So it's not systolic failure. Here you have defect during filling. So we will count it as diastolic heart failure. Diastolic heart failure. Diastolic heart failure. In acute pulmonary edema with heart failure, see, in acute heart failures, for a very short period of time to improve the ventricular force of contraction, we can use inotropic agents. But the more longer I use it, higher the chance of mortality. So that's why it's not a long-term treatment solution for patients with heart failure. Just to give you an example or an analogy, I may consider using steroids for treatment of severe attack of asthma. But if I use it long-term injectable or oral steroids, it's not safe. It will lead to a lot of consequences. So during acute severe attack of asthma, we do use steroids, but not regular. Similarly, inotropic agents may be used during acute decompensation or sudden worsening of heart failure, but not for the regular management of heart failure. Okay, so these are the basics I want you to remember. Now, I also want you to remember that if ejection fraction is more than 40 and less than 50, we will call it as heart failure with mid-range ejection fraction. Okay, now let's go to the next question. Here we have a 70-year-old patient with history of heart failure, presents with worsening dyspnea and fluid retention. Lab tests reveal an elevated serum potassium of 5.8. Which of the following medication should be avoided in this patient due to potential for further increase in serum potassium? This is a pretty simple and straightforward question. Yes. In fact, even ACE inhibitors are known to cause hyperkalemia. We should keep in mind. But in the exam, it's always about making the most likely. See, the question never, generally questions don't ask which of the following or all of the following. They ask most likely. So even if there are 2-3 possible answers, among them, which one is most likely is what we are supposed to choose. So furosemide makes you excrete more potassium. So that will not be a problem. So what will be a problem here? Potassium sparing diuretics and lisinopril. So I want you to remember both. ACE inhibitors also contribute to hyperkalemia, but this potassium sparing diuretics cause the maximum hyperkalemia. So we will choose spironolactone as our answer. This spironolactone needs to be avoided in this patient. So that will be our answer. Good. I think most of you have answered this right. Good. Now, next was this question. Which of the following classes of medications is commonly used for symptom relief in patients with heart failure but does not reduce mortality? I think this is the point that some of you were addressing. Now we have reached the right answer. ACE inhibitors, they decrease mortality. ACE inhibitors decrease mortality. Beta blockers, they also decrease mortality. Diuretics, they do not decrease mortality. Mineralocorticoid receptor antagonists are nothing but your spironolactone and so spironolactone is an antagonist for aldosterone receptors. So spironolactone and eplerenone are aldosterone receptor blockers. So they are associated with mortality reduction. So they also decrease mortality. So here diuretics can be used whenever there is worsening of heart failure to reduce the edema and the pulmonary edema, but they don't decrease the mortality. So option C will be the right answer. Similarly, I can use digoxin to reduce the symptoms in the acute condition, but they don't decrease the mortality. In fact, they increase the mortality. Okay, a patient with heart failure is started on beta blockers to reduce mortality and improve symptoms. Which of the following adverse effect is commonly associated with beta blocker therapy in this case? What is the most common adverse effect of beta blockers? Of course, beta blockers don't cause hyperkalemia, don't cause peripheral edema, don't cause hypertension. In fact, beta blockers cause decrease in blood pressure. One of the side effects of beta blockers is bradycardia. To be very frank, in a patient with heart failure, this bradycardia is not a side effect, but it is beneficial. We want to keep the heart rate low in a patient with failure, because जितना heart rate ज़्यादा है उतना ही myocardial oxygen demand बढ़ेगा. More the myocardial oxygen demand, so if I have ischemia, I may not be able to deliver that oxygen and I will end up worsening the heart failure. We want to keep the heart rate low, so this is not primarily a concerning side effect. But because they are asking in this question, we will go ahead with option B. Good. Which of the following diagnostic test is most useful for assessing the severity of heart failure and monitoring treatment response? Monitoring treatment response. Is it troponin, chest X-ray, BNP levels, or electrocardiogram? What is the most useful? Crazy physician, good. So when we have heart failure, that echo that we do for assessing the ejection fraction is only done at the initial diagnosis. And after that, if you're suspecting any other changes, not for monitoring the response to treatment. So whenever heart fails, there is stretching of the atria. And the stretching of atria releases the ANP and BNP. And these levels correlate with the burden on the atria. More the burden or more the stretch of the atria, more BNP will be released, more ANP will be released. So indirectly it correlates on how much heart is failing. More BNP is more severe heart failure. Less BNP, less severe heart failure. And I can use it for assessing the treatment response. If let us say I started with, for the diagnosis, BNP more than 125 picogram per ml is highly suggestive of heart failure. It is suggestive of heart failure, especially if the patient is having symptoms. So let us say when I started treatment, patient BNP was 250 picogram per ml or 700, 900 picogram per ml. Let us say 1000 tha. Once I started treatment, I started him on beta blockers, SC inhibitors, and then the spironolactone, SGLT2 inhibitors. When he comes back for follow-up, I expect the BNP levels to be down from 1000. I now want it to be less. If it is decreasing, that means he is responding to treatment. But if it is not, it means he is not responding to treatment. So BNP levels not only help in diagnosis, they are useful in diagnosis, but they're also useful in monitoring the treatment response. So option C is going to be our right answer here. Good. Next. Which of the following is a surgical intervention that may be considered for select patients with advanced heart failure who are refractory to medical therapy? कौन सा सर्जिकल इंटरवेंशन हार्ट फेलियर में यूज हो सकता है व्हेन मेडिकल ट्रीटमेंट फेल्स? हाँ, यू आर गिविंग SGLT2 inhibitors, ASC inhibitors, ARPs, beta blockers, diuretics, spironolactone, and maybe the ARNI, the sacubitril as well. Still patient is not responding. So which of these can be useful? The surgical intervention. Said Usman, good. So we will call it as left ventricular assist device. So what is this left ventricular assist device? When heart is failing, medications are not helping, we can connect the heart to a pump, and the job of pumping is now done by the device and not by your own heart. Then we will call it as left ventricular assist device. So basically ये होता क्या है, ये heart है patient का. This is the aorta. What we will do is we will connect this heart to an external pump. So the blood from this aorta is taken up by this external pump, and this external pump will now pump this blood back to the aorta. Instead of this pumping job that see atria से हम blood receive करेंगे, then ventricle has to supposed to eject it to the aorta, but now this ejection job is done by this external pump. Now this external pump will of course require a pumping device. It will require a pumping device, and it will require the energy, battery, power, all of that. So patient has to have a suit where he should wear a suit that contains the battery pack and necessary cables, everything outside his body, and a pump from all the connection is with that pump. The pump is now collecting the blood from the patient's ventricle and pumping it to the aorta. This arrangement of this device is called as left ventricular assist device, or LVAD. because it is assisting the left ventricle in ejecting the blood to aorta. It is assisting the left ventricle to eject the blood into the aorta. It is called as LVAD. Where is it used? It is used for refractory heart failure, non-responding to or non-responsive to medical therapy. Now, this is not a great solution as of now because of the infection risk, and also it's not considered for those patients where I don't have a better solution available. What is the better solution? Cardiac transplantation. So right now, if I'm waiting for the cardiac transplantation, some donor to be available for me during this period of cardiac transplantation, you can put me on left ventricular assist device, so that will help me to live till I find a donor. Not a long-term solution. So currently it is used as a bridge to cardiac transplantation, and still you find a donor, we can help you by putting you on this left ventricular assist device. Okay, so here our answer is going to be left ventricular assist device. It's a surgical intervention, not a simple medical procedure. It's done only for those patients who are having advanced heart failure, which is not responding to the conventional medications, and we are probably hoping that we will find a donor for cardiac transplantation. So till that happens, as a bridge, we are using this. Okay, next question. A 30-year-old otherwise healthy female presents to emergency department with sudden palpitations, chest discomfort, and lightheadedness. On examination, her heart rate is 180 beats per minute, regular, and there are no other abnormal findings. Vagal maneuvers are unsuccessful in terminating the tachycardia. What is the appropriate initial treatment? Okay, so what do you think should be the answer here? Well, there is no ECG image given and no detailed description of the ECG findings available in the question. So I cannot come to the conclusion which arrhythmia this examiner is talking about. But unfortunately, these are the kind of questions they keep cropping up every now and then in our exams. So let us see how do I deal with it. Healthy emergency department, palpitation, chest discomfort, lightheadedness, heart rate is 180, regular. There are no other abnormal findings. One thing I can be confident here is that it is not ventricular fibrillation, because patients of ventricular fibrillation will generally present with pulseless state because ventricle is not contracting, it is fibrillating, so it's not able to eject sufficient stroke volume, so they will be pulseless. I can also be sure that this question is not talking about atrial fibrillation, because in atrial fibrillation the pulse will be irregular. So I can presume that either it will be a VT or a supraventricular tachycardia. Looking at this, that they have tried vagal maneuver, it is pointing towards they would have thought of it as supraventricular tachycardia. So from the story, I am presuming that this question is talking about paroxysmal supraventricular tachycardia. And if I have to manage a case of paroxysmal supraventricular tachycardia, what is our approach? Whenever we think of managing a case of paroxysmal supraventricular tachycardia, we look at the BP. If the patient's BP is less than 90/60, we always go for shock. The form of shock that we use here is cardioversion. I keep telling you repeatedly again and again, the defibrillation form of shock is only for two conditions. एक है ventricular fibrillation, second है pulseless VT. For every other arrhythmias, if you have to give shock, cardioversion. Every arrhythmia BP less than 90/60, shock is the treatment. If BP is more than 90/60 in these patients, so as first line treatment, we can try vagal maneuvers, trying to activate the vagus nerve like neck, cervical carotid massage, or modified or the original version of Valsalva maneuvers. These are vagal maneuvers. If they fail, second line we think of drug. And what is the second line? The drug of choice, as we call it as, the drug is going to be IV adenosine. So IV adenosine will be our default choice. IV adenosine, 6 mg, 12 mg, 12 mg, 3 doses. First dose and second and third doses will be of 12 mg. So when adenosine fails, we will think of cardioversion here. Third line is going to be cardioversion again. So here, because patient was unstable, we have directly gone for shock. Here patient is stable, so we try first physical maneuvers, if not drugs, if not cardioversion. So here they have already tried the vagal maneuvers, unsuccessful. So we are going to go ahead with adenosine as our answer. I would have been more happy if the question had an ECG image so that I could have confidently diagnosed it as PSVT. Ram, yes, the dose is same. Okay, now which of the following ECG finding is characteristic of PSVT? So in the previous question, we were talking about PSVT. We made a presumption that it is PSVT. Now they are asking about PSVT. ECG description of PSVT. Is it narrow complex tachycardia with absent P wave? Wide complex tachycardia with bizarre QRS morphology? Regular atrial fibrillation with rapid ventricular response? Irregular rhythm with varying QRS complexes? What is the best description? What do you think is the best description? Yes, of course. PSVT is a narrow complex tachyarrhythmia. And in a narrow complex tachyarrhythmia, QRS will be less than 120 milliseconds. Each QRS will look same. There will be no bizarre morphology or varying QRS complex morphology. The varying QRS complex morphology we are typically getting in polymorphic VT. Second, P waves. P waves are usually difficult to identify in a patient with PSVT, similar to atrial fibrillation. But in atrial fibrillation, RR interval will be varying. Here, RR interval will not be varying. So, keeping all these points in mind, we can go ahead with option A as our answer. Right? Narrow complex tachycardia with absent P waves. Next. Which of the following echocardiac findings is characteristic of sustained monomorphic ventricular tachycardia? Irregular rhythm with varying QRS complexes. Regular wide complex tachycardia without discernible P waves. Narrow complex tachycardia with absent P waves. Prolonged QR interval with T wave inversion. Prolonged QT interval with T wave inversion. Yes, the monomorphic VT usually looks like this. When you see the X-rays, you will see ECGs, you will notice that in monomorphic VT, every complex QRS in a given lead looks same. So whenever in the ECG, we have a wide complex tachyarrhythmia, our approach is primarily going to focus on three arrhythmias that are wide. The first one is VT, second one is VT, third one is VFib, third one is ventricular fibrillation. In ventricular fibrillation, two things are there, ECG findings. The first one, the QRS amplitude or voltage is low. QRS amplitude and voltage is low. Polymorphic VT and torsades pointers are not exactly same. Torsades pointers is one of the cause for, or like one of the type of polymorphic VT. Polymorphic VT is a broad term. Under that, one of the types of polymorphic VT is torsades pointers. Okay, I'll come to that. So in ventricular fibrillation, the QRS amplitude will be less. What do you mean by that? The height of QRS will be less. When do I call it as less? I will call it as not less if it is more than 1 millivolt or two large boxes in the chest leads, and more than one large box in the two large box in the chest lead, one large box in the limb lead. If it is more than that, it is not low. If it is less than that, it is low. Second, we will have varying QRS morphology. So if it is looking like, to give you an example, if you get waves something like this, where the voltage is less, it's not more than 1 millivolt in chest leads, more than 0.5 millivolts in limb leads, and the morphology appears. This is different from this is different from this, so morphology is varying. Then it is ventricular fibrillation. If it is ventricular tachycardia, it is of two types. The first one is monomorphic VT, where in a given lead all the complexes look same. I may not be sketching it perfectly same because of course I'm a human and our hand movements may not be perfect. But if in a given lead, all the complexes look same. Wide QRSs, but regular heart rate. Wide, similar, wide QRS complexes, wide, regular QRS complexes with similar QRS morphology. There is no variation in QRS morphology. Then we are going to call it as monomorphic VT. So this VT is monomorphic. Morphology is same. Morphology of QRS is same. And then we will have a polymorphic VT where morphology of QRS keeps varying. So here one QRS may look like this, the next like this, next like this. So there is a variation in the QRS morphology. I mean, don't expect the exam image to exactly look like this. If it is a wide complex tachyarrhythmia where QRS don't look like same and voltage is not low, you will count it as polymorphic VT. So here also you have wide irregular QRS complexes with varying morphology, varying QRS morphology. Then it is polymorphic VT. Now in this polymorphic VT itself, we have a subtype. Now I will show you one more VT, which is a subtype of polymorphic VT, where QRS morphology is varying. This is different from the next QRS. This is different from the next QRS. This is different from the next. This is next. This is next. So this QRS morphology is different. Again, it's different. So each QRS is not looking same. They are all wide QRSs. Voltage wise, it's not very low. One QRS looks different from the rest. So this is technically what it is, polymorphic VT. But in this patient, if I draw a baseline in the middle, the QRS complexes appear to be going up and below this, or its QRS complexes appear to be twisting around this baseline. Such kind of polymorphic VT will be called as torsionis de pointis or TDP. This is a form of or a type of polymorphic VT. Now this kind of polymorphic VT, the torsionis de pointis, is typically more common in patients with QT interval prolongation. So whoever has QT prolongation, in them this is more common. Like in patients with hypomagnesemia, where QT interval can be prolonged, or patients with congenital long QT syndrome, where it can be prolonged, or drug-induced QT prolongation. In all of them, the chances of developing torsionis de pointis or polymorphic VT is high. So these are all our different types of wide complex tachyarrhythmias. Now, which description fits the monomorphic ventricular tachycardia? Regular wide complex tachycardia without discernible P waves. Option B fits the description that we just learned. So that will be our right answer for this question. Now moving to the next question. Which of the following medication is commonly used for acute management of hemodynamically stable monomorphic ventricular tachycardia? We just learned about monomorphic VT. Which of them will be useful? So remember, whenever we are talking about management of a wide complex tachyarrhythmia, wide complex tachyarrhythmia management, under that we have VT and VF. So how am I going to manage? We will put VFib and VT patients whose pulse is not felt, VT without pulse, in one basket. And then those patients where we have VT but pulse is felt, VT with pulse, in two different baskets. So VFib and VT without pulse. These patients should be treated by default with defibrillation. Defibrillation. Apart from that, because most of these VT without pulse patients, there is no pulse. VFib invariably there will be no pulse. So they would of course require CPR till we can correct this rhythm back to normalcy. If VT is there with pulse, then we will go ahead and check their BP. If they're hemodynamically unstable, BP is less than 90/60, we need to go for shock. The form of shock that we're going to use will be cardioversion. So I want you to remember that defibrillation is used only for these two arrhythmias. Any other circumstance where you need to give shock, by default it will be cardioversion. And if it is more than 90/60, then you don't have to go for shock, you have to go for drugs, pharmacotherapy or pharmacological cardioversion. For pharmacotherapy, the drug of choice for monomorphic VT is amiodarone. Amiodarone is the drug of choice. Alternatively, you can consider using lidocaine. And if it was Torsades the pointis, then we would have used IV magnesium sulfate. IV magnesium sulfate is considered as the drug of choice for Torsades the pointis. So in this question, it is not Torsades the pointis. So we will choose amiodarone. We will choose amiodarone. So what is going to be our answer here? Our answer will be amiodarone. Adenosine is useful for PSVT. Verapamil, being a calcium channel blocker, is also useful for supraventricular arrhythmias, including atrial fibrillation. Okay, next question. A 55-year-old female with history of heart failure presents with sudden cardiac arrest. An initial rhythm strip shows irregular, rapid, and chaotic QRS complexes. Which of the following is the most appropriate initial step in management? Patient is known case of heart failure with sudden cardiac arrest. An initial rhythm strip shows irregular, rapid, chaotic QRS complexes. It's a known case of heart failure. They have already presented with cardiac arrest. What is the next best treatment? Of course, whenever someone has a cardiac arrest, what is the first step? Start CPR, then try to identify the cause and then treat. So here we should of course start with CPR. On this patient most likely is going through ventricular fibrillation. Heart failure is a risk factor for ventricular fibrillation. And then once CPR initiated, defibrillator is available according to this rhythm, we should shock it because it appears to be ventricular fibrillation. Okay, next question. A 70-year-old male with history of prior myocardial infarction develops recurrent episode of ventricular fibrillation. Despite optimal medical therapy, he is stable and awaiting further management. Which of the following intervention is indicated to reduce the risk of recurrent VT? So in the previous question, we just learned that he had heart failure. And I told you heart failure is a risk factor for VT and VF. So this patient appears to have developed VF and landed up in this arrest state. So is there anything that we can do in this patient so that he doesn't land up in this arrest state? So please remember, to reduce the risk of cardiac arrest and ventricular fibrillation and tachycardia in a patient with heart failure, there are preset guidelines. So there is a patient with heart failure. What guidelines recommend? These heart failure patients are associated with increased risk of sudden cardiac death. And that usually happens due to ventricular tachycardia or ventricular fibrillation. So how can I prevent this? The preventive strategy that we can follow is, please put the patient on implantable cardioverter defibrillator. And anyone with a ejection fraction less than 35% carries very high risk of carries very high risk of developing this sudden cardiac death to VT with VT or VFib. So it is more wise to consider these patients to be on ICD. What is ICD? Implantable cardioverter defibrillator. So there is already a lead present in your cardia, and whenever it senses that the rhythm is going into VT or VF, it will deliver a shock so that it prevents the cardiac arrest. So what should be the answer here? Implantable cardioverter defibrillator that reduces the risk of recurrent ventricular fibrillation. CABG is for treatment of ischemic heart disease. Long-term oral prophylactic antiarrhythmic drugs is not considered as a wise idea, not a good idea. Cardiac resynchronization therapy is usually considered in patients with heart failure if they have bundle branch blocks also. So when they have bundle branch blocks, one of the ventricle is getting depolarized ahead of the other. So there is an asynchrony between ventricles contractions. Like for example, left bundle branch is blocked, then right ventricle gets depolarized ahead of the left. So to get that synchrony back, we follow cardiac resynchronization therapy. This is for heart failure patients with EF less than 35% and LBBB or RBBB. So there should be bundle branch blocks for us to think about resynchronization therapy. So that's not my answer here. Next, a 65-year-old post-menopausal woman presents to the emergency department with sudden onset chest pain and shortness of breath following an intense emotional stressor. She has a history of hypertension but no prior cardiac issues. Examination, she appears distressed, BP is elevated, and her cardiac evaluation reveals a new systolic murmur. ECG shows ST segment elevation in anterior leads. Troponin levels are mildly elevated. Echocardiography reveals apical ballooning and a preserved basal function. Which of the following is most likely diagnosis? So there are plenty of clues here for you to reach the diagnosis. You don't have to pinpoint each findings and have an explanation. Exam hai, bas ultimately diagnose tak pahunchna. So what are the key clues I can expect? Sudden onset chest pain and shortness of breath after an intense emotional stressor. Any question where examiner is talking about emotional stressor, हमें पता है किस चीज की बात हो रही है, right? इसके बाद अगर patient developed heart failure, what is he talking about? Then echocardiography में और एक clue मिल रहा है apical ballooning. So what is the diagnosis in that case? Yes, the question is talking about Takotsubo cardiomyopathy. The question is talking about Takotsubo cardiomyopathy. So options are definitely there. Takotsubo cardiomyopathy is here. So we will choose the Takotsubo cardiomyopathy as our answer. Right. Okay. Next. Just because we're talking about it, what is the most common cause for Takotsubo cardiomyopathy? The surge of catecholamines that happens when someone faces sudden emotional stressor. There is increase in adrenaline, noradrenaline, dopamine, which is responsible for these manifestations of Takotsubo cardiomyopathy. Okay, next is we have a 70-year-old woman with a history of recent emotional stress and presents with acute onset chest pain dyspnea. She is hemodynamically stable with no significant past medical history except well-controlled hypertension. ECG shows T-wave inversion in anterior leads. Cardiac enzymes are elevated. Coronary angiography reveals normal coronaries without any obstructive lesions. Okay, I think this is a kind of a repetition of the same question. Echocardiography demonstrates apical ballooning with hypercontractile basal segments. What is the most likely diagnosis? Again, this is pretty same story, same question. So we can stick to Takotsubo cardiomyopathy as our diagnosis. Stress-induced cardiomyopathy is another term for Takotsubo cardiomyopathy. These are not two different entities. Takotsubo cardiomyopathy is also known as stress cardiomyopathy. That is also known as apical ballooning syndrome. This is also known as, what are the other names for Takotsubo cardiomyopathy? It is also known as broken heart syndrome. It's also known as broken heart syndrome. So these are all the alternate names we should be familiar, because any of the name may appear in the exam. Now, which of the following is a postural tremor? Pill rolling tremor of Parkinson disease, wing beating tremor of Wilson disease, or fast pointing in cerebellar dysfunction, or both A and B. So, quick revision of tremors. So, what are tremors? Tremors are hyperkinetic movement disorders where the same movement keeps repeating again and again. We will call it as rhythmic movement disorder. Means there is a, with rhythm, same movement keep repeating again and again. Then we will call it as tremors. Now, tremors, based on whether the tremors occur predominantly at rest or on exertion, or when the limb is put in a particular posture, we will classify them as postural tremor, rest tremor, and action or intention tremor. So we'll have rest tremors, action or intention tremors, and postural tremors. So the rest tremor, the classical example we have is the rest tremor of Parkinson disease, which is also called as pill rolling tremors. Pill rolling tremors of Parkinson disease is a classical example. Action tremor or intention tremor, the cerebellar dysfunction is a classical example. So when cerebellum gets affected, patient will have a tremor which is usually not there at rest, not there in any particular posture, but it comes whenever patient is having an intentional movement. So when he tries to reach out an object, the tremor kicks in. That's action or intention tremor. Postural tremors is where tremor comes when limb is held against the gravity in a particular posture. Like, for example, in alcohol withdrawal tremors, the tremor appears when you ask them to outstretch the hands like this, and then they start showing the tremor. So that tremor is called as postural tremor. So examples for postural tremor include essential tremor, then essential tremor, then drug withdrawal tremor, and then asterixis or flapping tremor, and wing beating tremor of Wilson disease. Wing beating tremor of Wilson's disease. So these are all our tremors. Okay, so is that clear? Now, looking at this, what is the postural tremor in the given options, which can be considered as postural tremor in the options that you have? Pill rolling tremor of Parkinson disease is a resting tremor. It's a resting tremor. The wing beating tremor in Wilson disease, the wing beating tremor is where the tremor kicks in when you ask the patient to elevate their shoulders, bring their hands closer at closer to eye level. Then they start having this wing beating tremor. So it is a postural tremor. The tremor won't be there when the limb is at rest, or it will be minimal. The tremor is not there when I'm trying to make movements, but the moment you ask me to hold the limbs in this position, the tremor comes. So this is going to be classical postural tremor. The cerebellar dysfunction causes action or intention tremor. So our answer is going to be option B. In postural tremor, we are going to get this. Postural tremor, we are going to get this in Wilson disease, the wing beating tremor. Okay. Next, a 54-year-old presented with loss of strength in his left side of the body, which lasted for 2 hours, after which he completely recovered. Which of the following can help predict the risk of overt stroke? Means, now what is the diagnosis here? From the story, the diagnosis is going to be transient ischemic attack. Transient ischemic attack. Why is this TIA? Because if focal neurological deficits resolve within 24 hours without an objective evidence of infarction, we will call it as TIA. So here there is no mention of any CT scan showing any infarction. So there is no evidence of infarction. Symptoms have resolved within 2 hours. In that case, we will call it as TIA. So if the symptoms resolve within 24 hours, TIA refers to resolution of neurodeficits within 24 hours without objective evidence of infarction, then we call it as TIA. Now, if the patient has developed an episode of TIA, that means he has risk factors for stroke. This time he was lucky enough, symptoms have resolved within 24 hours. Next time, no certainty. He may develop an overt, frank, full-blown stroke. So we want to assess the risk of frank or full-blown stroke. So which of the following scoring system can be used? Yes, it is ABCD2 score. ABCD2 score. ABCD2 in itself is a mnemonic. Where do I use this Charto-DS2 VAS score? It is used to decide need for anticoagulation in atrial fibrillation patients. Has blood score is used to decide or to calculate risk of bleeding when we start anticoagulants. So risk of bleeding is used for calculation of risk of bleeding before starting the anticoagulants. Midas questionnaire is used for assessing the impairment of quality of life by migraine. It is used in migraine patients to assess impact of migraine on patient's life. So answer, we will stick to option B, ABCD2 score. Next, a 50-year-old presented with raised JVP, pedal edema, and tender pulsatile hepatomegaly. On examination, this patient had pan-systolic murmur heard in the left lower parasternal region during inspiration. Which of the following is most likely diagnosis? So let me put it on map. So here we have a patient who presented with JVP raised. JVP is raised. This fellow has hepatomegaly. The liver is enlarged. And on examination in the left lower parasternal region, in this region, there was a murmur. Which murmur? It was pan-systolic murmur. So what is the diagnosis we are thinking of? Every information we need is there. Looking at the symptoms, we know that this patient is having a right-sided heart disease. He has raised JVP, hepatomegaly. So it's a right-sided heart disease. So I'm already thinking about pulmonic and tricuspid valves. There is no description of any left-sided symptoms. Whenever left-sided heart gets affected, we will have dyspnea, orthopnea, PND. So those symptoms are not there. So keeping those in mind, I can rule out few from the options. Mitral regurgitation and aortic stenosis can be kind of ruled out. I have to choose pulmonic stenosis and tricuspid regurgitation. In pulmonic stenosis, we have an ejection systolic murmur. Where is it heard? Pulmonic area, which is left second intercostal space. In tricuspid stenosis, what do we get? In TS, we get pan-systolic murmur. Where is it heard? The tricuspid area, which is left lower sternal border or left lower parasternal region. So looking at the description of the murmur and the findings, I think we can stick to our belief that this question is talking about tricuspid regurgitation. Tricuspid regurgitation. So now I will give you an approach. Whenever you get this kind of a question, all I want you to see is whether the symptoms are of left heart or right heart. If orthopnea, dyspnea, PND, it's left heart. raised JVP, hepatomegaly, ascites, right heart. So if you have a right heart problem, think of right valves. If it is left heart problem, think of left valves. Second, all these questions often mention from which area the murmur is best heard. So look at that. This area is actually tricuspid area. So I already know that this question is talking about tricuspid. Third, then look at the murmur. So I want you to remember about all the murmurs. So let us say we're looking at all the major areas. So on the right, second intercostal space, left second intercostal space, left third intercostal space, left first intercostal space, and left lower sternal border, we have different areas. The left first intercostal space, this is left side, this is right side. So left first intercostal space is our Gibson's area for murmur of PDA. Murmur of patent ductus arteriosus. Left second intercostal space is the pulmonary area or pulmonic area. Left lower parasternal region, left lower parasternal region is for the tricuspid area. And this is tricuspid area. And left third intercostal space is our aortic, new aortic area. We will call it as new aortic or 𝐒𝐝's area. New aortic or 𝐒𝐝's area. And the right second intercostal space is going to be our aortic area. So any question that talks about murmur and it mentions the area, just look at the area and you know from which valve it is coming. A murmur heard here is most likely aortic valve murmur. A murmur heard here is pulmonic valve murmur. The one heard here is again aortic. The one heard here is tricuspid. So in this question, they're mentioning that the murmur is coming from the tricuspid valve because it is heard in lower parasternal region. So that helps me to reach closer to tricuspid. And we already know that tricuspid regurgitation causes systolic murmur. So everything fits into the description. So option B will be our right answer. Now next. Anticoagulant of choice for patient of RHD and mitral stenosis presenting with atrial fibrillation. Warfarin, dabigatran, apixaban, ticagrelor. So the point to note here is whenever we have atrial fibrillation, there is increased risk of stroke. The reason for stroke in atrial fibrillation, atria is not contracting. So we may have a clot in the left atrium formed. Contraction means stasis is there. Stasis, according to which was tried, is a risk factor. So we'll have a clot in the left atrium. The clot in the left atrium can make its way into the left ventricle. From there, it can make its way into the aorta, aorta to carotid, carotid to brain. So atrial fibrillation is associated with increased stroke risk. And to minimize that stroke risk, we need to consider anticoagulation. We need to consider anticoagulation. And for that, again, anticoagulation is not required for all patients of atrial fibrillation. So we assess the risk. So if you have atrial fibrillation, how do you assess the risk? We assess risk with what we call as CHA2 DS2 VASC score. CHA2 DS2 VASC score. And if the score is more than or equal to 2 for males and more than or equal to 3 for females, we need to start them on anticoagulants. Those who have score less than this, we will start them on antiplatelets. So these patients need to be started on anticoagulation or anticoagulants. Now, first MCQ they will ask you is in what circumstance you will directly start anticoagulants without looking at the score. In what kinds of atrial fibrillation we start the anticoagulants without looking at the score. Anticoagulation without CHA2 DS2 VASC score. So that is indicated in first, all patients with rheumatic heart disease or valvular heart disease. If I develop atrial fibrillation because of valvular or rheumatic heart disease, you don't have to calculate the score and give me just aspirin. You will directly start them on anticoagulants. Second, in patients with previous stroke, even if you want to calculate this score in these patients, previous stroke has got 2 points, so you will anyway qualify it. So you don't have to waste your time calculating. Third one is patients with hypertrophic cardiomyopathy. Even in hypertrophic cardiomyopathy, the risk of atrial fibrillation is very high, risk of stroke is very high. So we don't calculate, directly start. Now the question is, okay, we're starting, but what is the preferred anticoagulant? Because there are so many of them. There is warfarin, there is apixaban, there is zimelgatran, argatroban. So which ones I should use? For rheumatic heart disease, the preferred is going to be warfarin. For other patients, we are going to prefer using newer oral anticoagulants or NOACs like the apixaban, dabigatran, zimelgatran. Those will be preferred over warfarin. But for valvular heart disease patients, we don't have large studies to say that okay, it is warfarin is as the newer oral anticoagulants are as safe as warfarin, so let us switch. No, we don't have that data or study yet, so we'll stick to warfarin for RHD patients. For other patients, we'll go ahead with newer oral anticoagulants. So now tell me, this patient is a case of rheumatic heart disease, and because it is RHD, the dabigatran, apixaban I can't use. Ticagrelor is an antiplatelet. Antiplatelet alone, see here, we are directly starting anticoagulants if it is RHD. Antiplatelet alone is definitely not enough. So this is antiplatelet, not enough. Apixaban is a newer oral anticoagulant. Dabigatran is a newer oral anticoagulant, NOACs. We could use them if this patient was not a case of RHD. But for a patient with RHD, only warfarin is the agent of choice. So that will be our answer for this question. Next, which of the following is not a contraindication for stroke thrombolysis? So it's basically a question about the thrombolysis. So which is not a contraindication? So what do you think is not a contraindication? BP more than 185 by 110 is a definite contraindication, because that BP more than 185 by 110, if I give thrombolytic agents, increase the risk of intracranial hemorrhage, which is a catastrophic event for a patient with stroke, because I already have an ischemic zone, now I have a hemorrhagic zone. Managing both becomes difficult, a big mess. Yes. Now, if you look at the guidelines for the stroke thrombolysis, stroke area more than 1/3 of the MCA territory is a contraindication, because already large stroke has happened. A stroke area of less than 1/3 is not a contraindication. It's either ideal and it's rather an ideal indication. This is a contraindication. Having coagulation disorders and recent MI, these are contraindication, but stroke area more than 1/3 of MCA territory is a contraindication. Less than 1/3 is not. Okay, next. A 34-year-old after chest trauma presented in a state of shock. On examination, patient had a BP of 60/40, heart rate of 130, distended neck veins, and raised JVP. On auscultation, breath sounds were heard faint and distant. Which of the following finding is unlikely to be present in this case? So what is the diagnosis here? So a lot of clues are there. Chest trauma, road traffic accident or whatever, chest trauma. Had a BP of 60/40, hypotension, distended neck veins or raised JVP, and auscultation breath sounds were heard faint or distant. So we have all the Beck's triad features here, right? So when we have Beck's triad, hypotension is there, raised JVP is there, and muffled heart sounds there. Yes. So this question is talking about cardiac tamponade. Cardiac tamponade. Once you know this is talking about cardiac tamponade, let's try to answer rest of the findings. They are asking which of the following finding is unlikely or not likely to be seen in this patient. Increased JVP, they have already mentioned there is raised JVP in the question. Yes, increased JVP is expected. Massive collection of fluid in pericardial space. Yes, the fluid here is blood, but that's fluid. Yes, this is true. Pericardial knock, absent Y descent on JVP. Yes, the pericardial knock is a feature of constrictive pericarditis. It is seen in constrictive pericarditis, not in patients with cardiac tamponade. So, what is this pericardial knock? Pericardial knock in constrictive pericarditis, the pericardium has become stiff, and because of its stiffness, it is not allowing the ventricle to expand fully. So, it can allow the ventricle only to expand till its limit of stretch is reached. So in the cardiac cycle, in passive filling, when we are filling the blood into the right ventricle, it is expanding and then suddenly the pericardial limit of stretch is reached. So it is made to stop. When it stops, it jerks vigorously. Basically, it was in a inertia of motion and then suddenly stopped. So it jerks. That jerking makes the noise. That noise we call it as pericardial knock. So pericardial knock is a feature of constrictive pericarditis and not cardiac tamponade. While absent Y descent on JVP, yes, it is definitely a feature of cardiac tamponade, because in cardiac tamponade, there is so much of blood or fluid in the pericardium that the right ventricle gets collapsed. And because of the collapse, filling blood into this right ventricle passively is not possible. So there is no passive filling in cardiac tamponade, only active filling happens. And that's why the Y descent becomes absent on JVP. So this is seen in cardiac tamponade, but not the pericardial knock, making that as our answer. So we'll put a small table because this is a kind of question that they are repeatedly asking. So we'll put a table comparing cardiac tamponade and constrictive pericarditis. Cardiac tamponade, we will only concentrate on what is important. Cardiac tamponade and constrictive pericarditis. First, with respect to clinical features, both of them have a lot of similarities. Both of them can have hypertension, both of them can have raised JVP, both of them can have hepatomegaly. So we'll concentrate on what is differentiating, not common. So in terms of cardiac tamponade, when we look at the JVP waveforms, the tamponade will have tall A wave. Constrictive pericarditis will also have tall A wave. But here in tamponade, we will have a prominent X descent, but absent Y descent because there is no passive filling. On the other hand, in constrictive pericarditis, because of tall A, Y descent will be prominent. Sorry, X descent will be prominent. And here, even the Y descent will be prominent. So we have absent Y descent in cardiac tamponade. We have prominent Y descent in constrictive pericarditis. So this is one point which is highly useful in differentiating, at least in the MCQs. I don't know how much we use it in real life, but in MCQs it is definitely useful. Second, auscultation sounds. On auscultation in cardiac tamponade, the sounds appear heard from distant. We call it as muffled heart sounds. While in constrictive pericarditis, we encounter pericardial knock. We encounter pericardial knock. So this table will help you to deal with the kind of questions that we just dealt. So here it was pretty sure that the question is all about cardiac tamponade. And in a patient with cardiac tamponade, pericardial knock is not expected. It is expected in constrictive pericarditis. Next question. Which of the following is not a diastolic sound? Pericardial knock, S3, opening snap, ejection click. Which of them is not a sound heard in diastole, rather heard in systole? Which of them? What do you think? Which of them is not a diastolic sound? Pericardial knock, S3. Krishnakant Bedi, perfect, perfect. So pericardial knock is seen in constrictive pericarditis, and what is the cause for it? sudden or abrupt cessation of diastolic filling of the ventricle, mainly passive filling restriction. S3 is because of the passive filling of blood into a dilated left ventricle. Again, passive filling, which is diastolic. Right? S3 can be seen in various conditions where there is left ventricular dilatation. Opening snap is the sound produced by opening of mitral or tricuspid valve if they are stiff and stenosed. It is seen in patients with MS and TS. Ejection click is sound produced by opening of aortic valve and pulmonic valve if they are stiff and stenosed. So you will see it in AS and PS. So now AS and PS, where the aortic and pulmonic valve open in which part of cardiac cycle? Systole or diastole? Of course, systole. In systole, we open the aortic valve and eject blood from ventricle to aorta. In a diastole, we open the mitral and tricuspid valve and transfer the blood from atria to ventricles. So this sound must be produced when aortic valve opens. Aortic valve opens in systole. So this will be a systolic sound. So ejection click is a systolic sound. S3, S4, sorry, S3S, S3, S4, opening snap and pericardial knock. These are all diastolic sounds. So we'll just map the relative positioning of all these sounds in cardiac cycle. So let us say this is my S1. This is S2. This is S1 again. So between S1 and S2, we have systole. Systole will have isovolumetric contraction as their first part. After the isovolumetric contraction is where the valves open. Opening of valves happen here. So if opening of valves produce a sound, which valves open in systole? Aortic valve and pulmonic valve. So if opening of valves produce a sound, it will be here. And this sound we are going to call it as sound produced by opening of aortic valve and the pulmonic valve. We will call it as click or ejection click. After that, you will have rapid ejection and slow ejection. After the ejection is over, we will have closure of aortic and pulmonic valve, and closure of aortic and pulmonic valve produces S2. So the valves are closed. Now we start diastole. We will have isovolumetric relaxation. After isovolumetric relaxation, this is where there will be opening of yes, Sairam. In mitral stenosis patients or in any RHD patient and in HOCM patients, we do not have to calculate the CHA2DS2 VASC. Directly start them on anticoagulants. Yeah, see, antiplatelets are not effectively going to prevent formation of a clot which is due to stasis. Antiplatelets will prevent a platelet plug formation if there is endothelial injury. But here the clot formation is due to stasis. Okay, so after isovolumetric relaxation, we will have passive filling. After passive filling, we will have active filling. Now, during the passive filling, passively blood is coming from atria to ventricle. Normally, it doesn't make a noise, but if my ventricle is dilated, it may make a noise. So if I'm hearing my S3, S3 is going to be heard somewhere here. If I'm hearing an opening snap, the opening snap will be heard here. So this is the position of hearing the opening snap. So this is the position of hearing the S3. And then if I'm hearing this so-called pericardial knock, so we are filling the blood into the ventricle, passive filling passive filling is going on, then abruptly the pericardium halts the passive filling. At this point of time, your ventricle vibrates and makes the noise. So this noise, we will call it as pericardial knock. Pericardial knock. Okay, now I get into the active filling. If no problem, active filling goes on, but then in the active filling, I'm trying to fill this blood into a compact left ventricle. If that is what is happening, then I will have another noise heard towards the end of active filling. And this noise, we are going to call it as S4. S3 is produced by passive filling phase in a dilated left ventricle. S4 is produced by active filling phase in a compact, concentrically hypertrophied left ventricle. Now, as you see, all these are diastolic sounds. Opening snap, S3, S4, and pericardial knock, these are all diastolic sound. The clicks, the ejection clicks are systolic sound. So, option D will be our correct answer. Okay, next, which of the following biological agent can be used for treatment of both type 2 and non-type 2 asthma? The asthma is classified into type 2 and non-type 2. The basis for this classification is in the inflammation, whether Th1, Th17 cells are playing the main role or Th2. If Th2 is playing the main role, then we will consider it as type 2 asthma. If Th2 cell is not involved, then it is non-type 2 asthma. The type 2 asthma is predominantly a eosinophilic asthma. So here Th2 cells are predominantly involved. Th2 cells involved means we will have elevation in IgE, then interleukin 4, interleukin 5, and eosinophils are the ones which are causing the inflammation. In non-type 2, there is no involvement of interleukin 4 or 5 or IgE in the pathogenesis. This is a basic thing that we need to remember. Then we will be able to decide. So now we have these monoclonal antibodies like omalizumab, which is monoclonal antibody against IgE. This is anti-IgE. Anakinra is anti-IL-1. Mepolizumab is anti-IL-5, and tezepelumab is anti-thymic stromal lymphopoietin. Now in type 2 and non-type 2, both cases, there is involvement of thymic stromal lymphopoietin. This is involved in pathogenesis of non-type 2 as well as type 2. So any drug that is targeting TSLP can help treat both non-type 2 and type 2. But drugs targeting IL-4 or IgE or IL-5 will only be useful for type 2. So this drug, mepolizumab, can only be used for type 2. Omalizumab can only be used for type 2. Anakinra is generally not used in management of any form of asthma. So this anti-TSLP can be used for both type 2 and non-type 2. Reason being TSLP is involved in pathogenesis of both, so I can target both. So our answer here is going to be option D. Sayed, good. Next, a 35-year-old person living with HIV presented with mild headaches. Her CD4 count was 110 cubic millimeter. CSF analysis showed cell count of 200 cells per cubic millimeter, 100% lymphocytes, CSF protein 180, CSF glucose 60, cryptococcal antigen was positive on CSF. Okay. Now, should I really waste my time trying to understand what CSF picture is suggestive of? Absolutely not, because examiner has given me the diagnosis. He has told that cryptococcal antigen was positive. That means this patient is having cryptococcal meningitis. And here it is also mentioned that the CD4 count of the patient was less than 200. The classical cocktail of cryptococcal meningitis. So diagnosis is here made apparent and clear by the examiner himself. We're talking about cryptococcal meningitis. If we had not mentioned the antigen positive, I would have still come to the diagnosis of cryptococcal meningitis by analyzing the CSF. Lymphocyte predominant CSF picture and plasma CSF glucose appears to be normal. Normal is 60% of blood glucose. It is 60%. So there is no decrease. So keeping that in mind, I could have concluded this as fungal meningitis with a background of HIV and immunocompromised state. Nonetheless, examiner has told me Now we know that for cryptococcal meningitis, amphotericin B plus flucytosine combination is the drug of choice. But once we have eradicated the infection, because he continues to be immunosuppressed or immunocompromised, we need preventive treatment. For that, the drug of choice is fluconazole, which has been started. Now here, examiner is asking you, how long I should continue fluconazole? Should I continue lifelong, or should I continue till CD4 count is more than 200 or 500, or just for 6 months? The answer is option B. Because once we are giving good antiretroviral therapy, immunity will improve, the CD4 count will improve. Once it comes above 200, he is no longer immunocompromised. He is no longer sitting at the risk of cryptococcal meningitis. But who knows, the next CD4 count may drop. Next, it may be again 150, right? So that's why we will not stop immediately as soon as it crosses 200. We will make sure that once it crosses 200, it remains elevated above 200 for at least 6 months. Then we will stop the fluconazole prophylaxis. So option B is the right answer to choose over here. CD4 count more than 200 consistently for at least 6 months. Okay, next one is, which of the following is the earliest detectable biomarker of MI? Troponin I, troponin T, CK-MB, ischemia modified albumin. If myoglobin is an option, what would you choose? Usman, right. Ischemia modified albumin is the earliest detectable marker after MI. So the way to remember is there is a sequence of elevation of these markers. So I want you to remember the sequence so that even if ischemia modified albumin doesn't appear in the option, let us say ischemia modified albumin is not there, myoglobin is there, then again it will be myoglobin. No, myoglobin is not there. Instead, there is, let us say, hard type fatty acid binding protein. Then what will be the answer? So if you know the sequence, we will be able to remember it. The sequence is ischemia modified albumin is the first one to appear, followed by hard type fatty acid binding protein, followed by that myoglobin, and after myoglobin, next we have CK-MB and troponins. Now you can remember this sequence with a mnemonic. The mnemonic is, I have my cat. I have my cat. Ischemia modified albumin, hard type fatty acid binding protein, myoglobin, CK-MB, troponin. I have my CK-MB-T, troponin, CK-MB-C, troponin, T. So this way you will be able to remember the sequence, and no matter what they ask, among the available sequence, you can always choose the earliest one. Like if these four are option, I can still choose the earliest one. If these are the option, I can still choose the earliest one. If these are the options, I can still choose the earliest one. So I want you to remember this sequence. I have my cat. Okay, good. Now here they have asked us to identify the mismatch. Means basically they're representing walls of the heart and their ECG leads. 2-3 AVF inferior wall, 1 AVL lateral wall, V1, V2 septum, V3, V4 posterior wall. Good. I think it's a pretty straightforward question. So in a standard 12-lead ECG, the inferior wall is represented by, this is inferior wall. Inferior wall is represented by lead 2, 3 AVF. This is lateral wall. It is represented by lead 1 and AVL for higher portions, V5, V6 for lower portion. Then behind this somewhere we have a interventricular septum. So for interventricular septum, we have lead V1 and V2. What you see front is the anterior wall. For the anterior wall, we have, good. We have V3 and V4. So in the standard 12 lead ECG, we don't have a representation of the posterior wall and a portion of the right ventricle. So if I'm suspecting posterior wall MI, I need to put additional leads posteriorly and take the ECG. Those leads will be called as, because now we have already labeled V1, V2, V3, V4, V5, V6. The additional leads will be labeled as V7, V8, and if you're putting 3 leads, you can label it as V9. So leads V7, V8, V9 will be considered as the leads for posterior wall. In normal 12 lead ECG, there is no representation of the direct representation of the posterior wall. But as you see the anterior leads, because if this is my heart, there is a concept of reciprocal leads. So if this is the heart, this will be my, this is the heart, this is my lateral wall, this will be inferior wall. I have an anterior wall and a posterior wall. So lateral and inferior are looking at each other from diagonally opposite directions, so they are reciprocal to each other. Anterior and posterior will be reciprocal to each other. So generally, whenever we see ST depression in anterior wall, there may be a posterior wall MI. In such cases, we suspect, put an additional lead, additional 3 leads or 2 leads, and record a separate ECG. So for posterior wall, V3 and V4 are not the leads. These are suggestive of anterior wall. So we will go ahead with option D as our answer. Next, a 20-year male was brought to the emergency department after collapsing in the gym. On examination, the carotid pulse was absent and the pupils were fixed, non-reacting to light. ECG was flat. Resuscitation was attempted, but the patient could not be revived. He is a known athletic player and has no significant past history. A provisional diagnosis of sudden cardiac death was suspected. Which of the following is the most common cause for sudden cardiac death in this patient? I think this is a pretty straightforward question. This whole story is a build-up. If I had read the last line, I would have already reached the answer. What is the most common cause for sudden cardiac death in young individuals and athletes? And that we know the answer. It is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the most common cause for sudden cardiac death in young individuals or athletes. So 2 MCQ points on this. They can ask you what is the most common cause for sudden cardiac death overall. The most common cause for a sudden cardiac death overall is ischemic heart disease, or you can also call it as coronary artery disease. Majority of the patient die because of a massive MI rather than any other cause. But if a young individual dies, less than 40-year-old, or an athlete dies, then in such cases, the most common cause going to be hypertrophic cardiomyopathy. The most common cause for sudden cardiac death in young and athletes going to be hypertrophic cardiomyopathy. Now again, remember, hypertrophic obstructive cardiomyopathy and hypertrophic cardiomyopathy are not two different diseases. Hypertrophic cardiomyopathy, when severe, it can lead to obstruction of the blood ejection from left ventricle to aorta, or left ventricular outflow tract obstruction. Then we start calling it as hypertrophic cardiomyopathy, hypertrophic obstructive cardiomyopathy. It doesn't mean that hypertrophic obstructive cardiomyopathy is the one which is always leading to death. People can die even if they don't have obstruction, just hypertrophic cardiomyopathy, because mostly the death does not happen because of obstruction, rather it happens because of arrhythmias like VT and VF usually due to ventricular fibrillation, ventricular tachycardia or fibrillation. So few points about hypertrophic cardiomyopathy before we move forward. It is an inherited disorder. It is not acquired. So there is a mutation usually in beta myosin heavy chain gene. And because of this mutation, they start developing the hypertrophy of the left ventricle. And when we're talking about left ventricle, they don't develop a uniform hypertrophy of the left ventricle. They will have asymmetric septal hypertrophy. So there is development of left ventricular hypertrophy for sure, they are adding more muscle mass into the left ventricle. But this interventricular septum asymmetrically grows. It grows inwards, trying to eat into the left ventricular cavity. So this we will call it as asymmetric septal hypertrophy, ASH. Interventricular septum is asymmetrically grown inwards. Now this is a highly muscular interventricular septum, and the papillary muscle attached to it, the papillary muscle that is attached to it becomes more stronger. So it can pull the anterior mitral leaflet towards it during systole. So that's that finding we will call systolic anterior movement or systolic anterior motion. So this mitral leaflet moves anteriorly because of the pull of the more stronger muscular papillary muscle attached to the interventricular septum, because interventricular septum has become highly hypertrophic. We will call it as systolic anterior motion or SAM. And now this ventricle assumes the shape of banana shaped left ventricle. So when these things are there in a question, that means examiner is talking about banana. Examiner is talking about hypertrophic cardiomyopathy. This is banana shaped left ventricle. These patients, as we just learned, has higher risk of sudden cardiac death due to ventricular tachycardia or ventricular fibrillation. So for them, the sudden cardiac death prevention is an important thing. So for that, what all we can use? We can consider using beta blockers and implantable cardioverter defibrillator. Beta blockers or implantable cardioverter defibrillator. Okay, good. So we will stick to our answer. It's hypertrophic cardiomyopathy. We were just discussing about it. Where do we get banana shaped left ventricle? We get that in hypertrophic cardiomyopathies. I forgot to address this point. For those who are not familiar, this is hypertrophic cardiomyopathy. Now the same patient, when this hypertrophy starts obstructing the flow of blood from left ventricle to aorta, then we will term it as hypertrophic obstructive cardiomyopathy. जब तक ये obstruction नहीं कर रहा है and the ejection is smooth, we will not label it as obstructive. We will just call it as hypertrophic cardiomyopathy. Next, a 50-year-old presents with chest pain. ECG is given below. Choose the correct combination of diagnosis and concerned blood vessel. So here we have the ECG. As we see ECG, we can notice ST elevation. Where all do we have ST elevation here? What all leads? Which leads show ST elevation? So to recognize whether ST elevation is there or not, we have to identify the J point, and the J point, if it is elevated above the baseline, then we will call it as ST elevation. What is the baseline? PR segment. PR segment is our reference point. So first I have to identify the J point and PR segment, then I will be able to say whether there is ST elevation present or not. So let's take the example of this lead 1 to assess whether there is ST elevation or not. This is P wave. I think you agree. This is PR segment. So PR segment हमारा baseline बनाती है. तो ये baseline हो गया मेरा. जहाँ पे भी PR segment दिख रहा है वो मेरा baseline है. This is the baseline. Now where is the J point? The J point is the end of QRS segment, end of the QRS complex. So wherever the QRS ends, that is the J point. Now how will I recognize the end of QRS? So when I trace this QRS complex, I see that it comes down here and then comes up. I count that it is ending here because after this it is forming an angle. So wherever I can see a sharp angle between the next wave and the end of QRS wave, that is my J point. So if this J point is above the PR segment, if it is above, then ST elevation is there. If it is below, ST depression is there. So in lead 1, PR segment and J point are sitting on the same level. There is no elevation. But if we look at lead V1, what is happening? This is the PR segment. This is inverted P here. So you can see the PR segment here. So that is the baseline now. Now I have to identify the J point. So ये PR segment है, then I can see that QRS का S is going down, coming up, 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 and here I can see an angle being formed. So there's an angle here. So this point will be counted as J point. So this is my J point. Now this J point is definitely above the baseline that we know, PR segment. It is above the PR segments. That means there is ST elevation in V1. Now I think you can agree that there is ST elevation in V2 as well, because this is PR segment and the J point is sitting here. Now we can agree in V3 also that there is ST elevation because the J point is sitting here. The S is ending here and clearly an angle is formed here. So this is the J point for V3. And I think we can agree that this is PR segment. J point is here. J point is above the baseline. So there is ST elevation in V4 as well. So we have ST elevation in V3, V4, V5. Do we have ST elevation in 2-3 AVF? No, we don't have ST elevation in 2-3 AVF. So in 2, this is P wave, PR segment. J point is here. See, the QRS ends here. It's ending here. PR segment is here. They're all on the same level. So there is no ST elevation in 2-3 AVF. We have ST elevation in V1, V2, V3, V4. So when we have ST elevation in V1, V2, V3, V4, where is the, what kind of MI it is? V1, V2 makes this septal. So we have ST elevation in V1, V2. So that makes it a septal MI. And V3, V4, we have ST elevation that makes it anterior. So we have anteroseptal MI, and we know that the blood supply to anteroseptal region comes from the branches of LAD. So our answer will be anteroseptal MI, LAD. Krishnakant, good. So we will stick to our diagnosis, right? So those who are not familiar, just a quick recap of the coronary supply of the heart. So this is my heart. Somewhere behind I have this interventricular septum. Now this is my aorta, and I will have my right coronary artery originate from this aorta and supply the inferior wall. Inferior wall is supplied by right coronary artery. Left coronary artery will divide into left anterior descending and left circumflex. Circumflex will supply the lateral wall. Anterior descending will supply most of the anterior wall, and it will also give the septal branches to the interventricular septum. Now this right coronary artery and the circumflex, we will posteriorly, they will form a synapse. They will have anastomosis posteriorly. So inferior wall is predominantly receiving blood supply from right coronary artery. Lateral wall is predominantly receiving the blood supply from left circumflex artery, and LAD is giving the blood supply mainly for the anterior wall and interventricular septum. So whenever we have anterior wall MI or septal MI, we think of LAD. If we have lateral, we think of circumflex. If both anterior and lateral is involved, then probably occlusion will be proximal to the bifurcation of coronary into LCX and LAD. If inferior wall is involved, we will think of RCA. So here it is septal and anterior. For septal, I have to block the LAD branches to septal. For anterior, I have to block the LAD. So if I block LAD, I can explain both septal as well as anterior wall MI. So that's why option B makes the right sense. Next, Lanzisi sign on JVP is seen in aortic stenosis, atrial fibrillation, AB dissociation, tricuspid regurgitation. Lanzisi sign. What is this Lanzisi sign? This is another name for fusion of CV waves. Fused CV wave on JVP. Then we call it as Lanzisi sign. Where is it seen? Lanzisi sign, fused CV wave. This is classically seen in patients with tricuspid stenosis. See, when I have atrial fibrillation, we know that we will have absent A wave of GVP. Absent A wave of GVP. When there is AV dissociation, what is the meaning of AV dissociation? There is no connection between atrial contraction and ventricular contraction. Normally, there is a beautiful synchrony, asynchrony between atrial and ventricular contraction. In the sense, P wave causes depolation of ventricle first, so atria first, so atria first contracts, then AV nodal delay, so PR segment, then ventricular depolarization starts, then ventricle contracts, right? So this is a normal sequence. But if haphazardly atria contracts sometimes, ventricle contracts sometimes, and there is no sequence involved anymore, then we call it as AV dissociation. That can happen whenever atrial rate increases more than ventricular, or ventricular rate increases more than atrial. So this can happen in patients with AV blocks, mainly the complete AV block, to be more precise, the third degree AV block or complete AV block. This can happen in ventricular tachycardia, ventricular fibrillation. There we get so-called Cannon A waves. What are these Cannon A waves? These are also tall A waves which appear intermittently and not continuously. These are tall A waves that appear intermittently. Okay. Then we have this tricuspid regurgitation. So in tricuspid regurgitation, basically what happens, you have a tricuspid valve which fails to close. So when I'm measuring the pressure inside the right atrium, indirectly I'm measuring the JVP, or directly I'm measuring right atrial, directly I'm measuring the jugular venous pressure, but indirectly it is representing the right atrial pressure. So let us say that I have tricuspid regurgitation, and when I have tricuspid regurgitation, what will happen to my pressure inside the right atrium? So let us say I am doing my active filling. I'm contracting and filling the blood into the ventricle. Tricuspid regurgitation doesn't create a problem here because the valve is anyway open at this point of time. Valve closes in systole. So A wave I will encounter normal sized, and I will have normal size X descent. Like let us say this is how the normal JVP looks like. I will have A wave, I will have this C wave, this X and X dash descent, and a V for venous filling and Y descent. Now what happens? I start the systole. Now I have a tricuspid regurgitation, I start systole. So in systole, as I start contracting the ventricle, I have blood in my ventricle. This blood is supposed to be ejected into pulmonary artery. But as the pressure builds up, the pressure gets reflected to the tricuspid valve also. In normal physiological state, this valve should be closed, and this generally doesn't open up in the opposite direction. Normal condition we're talking about in systole, when I start contracting and start exerting the pressure, maximum it can do is it can bulge into the right atrium and increase the right atrial pressure, giving rise to C wave. But now what happens, as soon as it bulges into it, it opens. That is the basic concept of tricuspid regurgitation. It cannot retain, it opens. And once it opens, the blood starts regurgitating from the right ventricle to atria. So what will happen to the atrial pressure? It will increase. In normal circumstance, that bulge is represented by C wave, but after that atria continues to relax, so we will have a decrease. But now we will not have a decrease in the atrial pressure. Because of this regurgitant blood coming into it, the pressure will raise. And remember, when I am doing this isovolumetric contraction for the C wave, ideally the valve should be closed, and I should be ejecting the blood here. When I'm doing this side, atria will be receiving the blood from veins, which gives rise to V wave. But now that the atria should be relaxing to give rise to X descent, that is taken away. And when I start filling, I'm filling more blood from the ventricle into the atria. So this V wave will become tall, and the C will become fused because the atrial relaxation is not happening. I have started adding blood into it. So the new waveform is kind of looking like this. it will start, but once the pressure builds up in the ventricle for the isovolumetric contraction, it pushes the valve. The valve is now open in opposite direction and the blood starts regurgitating. So now atria cannot relax because the blood is started regurgitating, means atrial pressure starts going up. And after this, the venous filling starts. Ideally, I should have got this X descent and then the venous filling would have started, but because regurgitant blood started coming, I did not get the X descent. Now from here, next step is venous filling itself. That will take, like, more blood coming into the atria will take the pressure more higher, and then after that, in the next passive filling, I will hand over the blood to the ventricle. So now my pressure will just keep going from C wave, it will keep going up, and then I will have Y descent. So now we have a new position for, so this is V wave, this is C, and this is Y descent. So now my C is fused with V. This fused CV wave is what we call as a Lances sign, and now V also has become more taller than A. So we have prominent V wave and the fused CV wave as findings of tricuspid regurgitation, and this fused CV wave is called as Lances sign. So in TR we get fused CV wave, that is Lances sign, and prominent or tall V wave, prominent or tall V wave. Okay, next one. Which of the following is not a fibrin specific thrombolytic agent? What is a fibrin specific thrombolytic agent? It is the one that only dissolves the fibrin, does not dissolve or damage other proteins. Non-specific are ones which not only dissolve fibrin, but they also dissolve other proteins. Like streptokinase is fibrin non-specific. RTPA, tenecteplase, alteplase are fibrin specific. How are they going to work? They do not directly go and dissolve the fibrin. What do they do is, body has a naturally fibrin dissolving enzyme, that is plasmin, which exists in the form of plasminogen. So these drugs, in normal condition, body activates this TPA and this plasminogen to plasmin by tissue plasminogen activator. This plasmin causes fibrinolysis. It breaks down the fibrin. So what these drugs do? RTPA is artificially produced TPA itself. Tenecteplase, alteplase are TPA analogs. They do the exact same job as TPA. They convert plasminogen to plasmin. Plasmin breaks down fibrin. Streptokinase can activate or behave like TPA, but it can also break down various other proteins because it is an enzyme breaking. It's an enzyme which is known to break proteins. It's not specific to fibrin. That's why it's not considered as a good drug for current management. Next, a patient died with suddenly after exercise. Autopsy image of the heart is given below. What is the diagnosis? I'm very sure all of you will be able to answer this. Yeah, this is a classical picture of hypertrophic cardiomyopathy, because here we can literally see a banana in the patient's heart. So you have a perfectly looking banana shaped left ventricle. That's why this is hypertrophic cardiomyopathy. So here again we can see that there is left ventricular hypertrophy. There is left ventricular hypertrophy. Then you can also notice that there is asymmetric septal hypertrophy eating into the left ventricular outflow tract. Now this is so muscular. This you can see the anterior mitral leaflet, the papillary muscle which is attached to it. It can forcefully pull it down. So this mitral leaflet can move anteriorly during systole. We will call it as SAM, systolic anterior motion. Next, which of the following is a classic feature of Parkinson's disease? Coriform movement, resting tremor, hemiplegismus, athetosis. Of course, now I know that you will be able to answer this. Which of the following is a classic feature of Parkinson's? Which of them is classic feature of Parkinson? See, coriform movement is usually seen in chorea. Chorea is usually seen in lesion of caudate nucleus. C for C. The lesion of caudate nucleus produces chorea. Hemibalismus or balismus due to lesion in subthalamic nucleus. Thalamic nucleus. Athetosis is due to lesion in putamen or globus pallidus. Putamen or globus pallidus. The resting tremor is the classical finding of Parkinson disease, where the lesion is there in the substantia nigra. Substantia nigra. So, what are the three cardinal manifestations of Parkinson disease? Resting tremor, bradykinesia, rigidity. These are considered as the cardinal manifestation of Parkinson disease. The resting tremor, bradykinesia, resting tremor, and rigidity. These are cardinal manifestations, right? We are going to call them as cardinal manifestations of Parkinson disease. You can also call them as motor manifestations of Parkinson disease, because the other symptoms like the resting tachycardia, orthostatic hypotension, constipation, REM behavioral disorder, and anosmia, they are all considered as non-motor symptoms of Parkinson disease. So resting tremor, we will stick to that. What is the hallmark of Guillain-Barre syndrome or GB syndrome? Ascending flaccid paralysis, ascending spastic paralysis, athetoid movements, intention tremor. So I think you already got the gist, you know the right answer. Intention tremor is a feature of cerebellar dysfunction. It's a form of action tremor. So it is seen in cerebellar dysfunction. Ascending spastic paralysis, where do we get? Okay, I know all of you got the answer right. Ascending flaccid paralysis is what you are getting in patients with GB syndrome, because GB syndrome is a disease of the peripheral nerve. It's a polyneuropathy. Polyneuropathy. And when we're talking about polyneuropathy, we're talking about LMN, because peripheral nerves contain lower motor neurons. So GBS is a lower motor neuron disease, and when you damage lower motor neurons, you will have decrease in reflexes, decrease in tone, and you will have flexor plantar response. In LMN damage, everything goes down. So that perfectly fits here. Okay, but where do we get this ascending spastic paralysis? Spastic means increase in the muscle tone. Typically happens when there is damage to upper motor neuron. Where do we get that? Athetoid movements or athetosis we just discussed. It is due to lesion in putamen or globus pallidus. Due to lesion in putamen or globus pallidus. Now, where do I get this ascending spastic? I have to cause damage to the UMN. So then it must be in the pyramidal tract somewhere. Spinal cord, brainstem, or brain. If I damage the brain or brainstem, I will end up with contralateral hemiplegia. But it will not be like ascending or descending. It happens once. So we get this classic ascending spastic paralysis if there is an extramedullary spinal cord compression in patients with extramedullary spinal cord compression. No, Krishna Gandhi. Ascending classically spastic we will get whenever there is damage to cortex, subcortex, brainstem, or the pyramidal tract in the spinal cord. But ascending spastic paralysis we get in extramedullary compression. A tumor comes and compresses the pyramidal tract. The neurons are arranged in a way that the sacral neurons are most lateral, then lumbar, then thoracic, and the cervical neurons are most medial. So tumor coming from outside usually compresses sacral, then lumbar. So lower limb becomes affected first, then thoracic, then cervical. So the progression will be ascending. Okay, next one. A patient with sudden onset severe headache, often described as worst headache of my life. This is most concerning for. I don't think none of you would have got it wrong. This is a pretty simple and straightforward. Worst headache ever is always subarachnoid hemorrhage. Okay, the multiple sclerosis, the characteristic finding on MRI is in multiple sclerosis. What is multiple sclerosis? It is a demyelinating disorder of CNS. It's an autoimmune demyelinating disorder of CNS. It's a demyelinating disorder of CNS. So demyelinating disorder of peripheral nervous system was our GB syndrome. Demyelinating disorder of central nervous system is multiple sclerosis. Other examples are neuromyelitis optica and myelin oligodendrocyte glycoprotein antibody disorder. It is usually due to an antibody, that is anti-myelin basic protein antibody. Anti-myelin basic protein antibody. Now, these antibodies and other cells will go and cause demyelination of CNS. Now, what is the most commonly affected site for demyelination? The most commonly affected site is the spinal cord. In the spinal cord, the long tracts. In the spinal cord, it's usually sensory tracts which are most commonly affected than motor. Sensory tracts are the most commonly affected site. Other sites where demyelination can happen, that includes cerebellum, optic nerve, and the subcortex of the brain, which includes the corpus callosum and other core of the brain, subcortex of the brain. Now here in subcortex, when demyelination happens, it may be affecting the corpus callosum. So when corpus callosum is getting demyelinated, like here I have this ventricle, fluid filled, CSF filled ventricle, and the corpus callosum is getting demyelinated. Those demyelinating plaques appear to be originating as small fingers coming out from the ventricle into the corpus callosum or the subcortex. This finding, as you know, is called as Dawson's fingers. And these demyelinating lesions, we will call it as plaques. And this is just outside the ventricle, so I can call them as periventricular plaques. So here the finding that we are expecting in a patient with multiple sclerosis is periventricular plaques. What I'm expecting here in the multiple sclerosis is periventricular plaques. These periventricular plaques are the ones which we will call them as Dawson's fingers. Basal ganglia calcification is not expected. Diffuse cortical atrophy is usually seen in age-related change or in patients with certain dementic disorders. Lacunar infarcts are usually seen in small vessel disease. Which neurological condition is characterized by triad of ophthalmoplegia, ataxia, and confusion? Ophthalmoplegia, ataxia, and confusion. Good. This confusion I can also replace with confabulation. Yes, good. It is usually seen in, we will have this internuclear ophthalmoplegia, confusion, and ataxia. A classical finding of Wernicke's or Wernicke-Korsakoff syndrome or Wernicke's encephalopathy. Myasthenia gravis patients usually present with ptosis, diplopia, and proximal muscle weakness, which generally increases as the day progresses. That means these all have a diurnal variation. Lambert-Eaton syndrome is also a neuromuscular junction disorder. So similar to myasthenia gravis in presentation, this also has diurnal variation, but the symptoms improve as the day progresses instead of symptoms worsening. Huntington disease, these patients can present neurological wise, they can have cardiac involvement. Neurologically, they present with chorea, the abnormal excessive movements which are dance like chorea. So this picture that they're painting here fits with the Wernicke's encephalopathy. Next, a patient with sudden onset unilateral facial weakness and difficulty closing one eye. What is the most likely diagnosis? Okay, again, this is a very simple, straightforward question. So I don't have to be being elaborate here. This is talking about myasthenia gravis. In trigeminal neuralgia, in Bell's palsy, right? In trigeminal neuralgia, there will be no weakness. They will have unilateral pain. So in trigeminal neuralgia, there will be unilateral short sustained pain in the distribution of the trigeminal nerve. This pain can be described as shock-like. And for these patients, shock-like pain, touch can be a trigger. Touch can be a trigger. So this is very similar to Sankt or Suna. So every time they touch or every time we touch the face, it triggers a shock-like sensation. That's a classical description of trigeminal neuralgia. There is no weakness. In myasthenia gravis, ptosis, proximal muscle weakness, diplopia we are seeing. So we will stick to Bell's palsy, which explains why there is acute onset weakness of one side of the face. Which of the following is a characteristic finding in Alzheimer's disease? Lewy body neurons, peak body neurons, neurofibrillary tangles, and amyloid plaques, or cerebral amyloid angiopathy. Classical or characteristic finding in Alzheimer's disease. So what is Alzheimer's disease? Alzheimer's disease is a neurodegenerative disorder, and neurodegenerative disorders generally occur because of accumulation of some inclusions in the neuron. For example, Parkinson's disease is a neurodegenerative disorder, their accumulation of alphas in nucleus. In Alzheimer's disease, it is due to accumulation of tau bodies. It is due to accumulation of tau proteins and amyloid beta and amyloid beta. And these accumulations in the neurons can be visualized under the microscope when we do biopsy. We will see them as neurofibrillary tangles and neuritic plaques. And if there are extensive depositions, we may be able to see these inclusions in the form of what we call as Hirano bodies. But what is commonly usually encountered? Neurofibrillary tangles and neuritic plaques. So these Lewy bodies in the neurons is typically seen in Parkinson's disease and Lewy body dementia. Lewy body dementia, LBD. Neurofibrillary tangles and neuritic plaques is amyloid neuritic plaques is what we're expecting in a patient with Alzheimer's disease. Okay. Next question. Before I go forward, in an Alzheimer's disease patient, if I do an MRI, what all findings I'm going to get? Where is the neurodegeneration starting first? Earliest affected part of brain in Alzheimer's disease. It is the entorhinal cortex. Entorhinal cortex, which is part of hippocampus. So hippocampus is the earliest affected part of the brain in Alzheimer's disease. That's why memory deficits short term are going to be the earliest symptom. The gold standard test for diagnosis of myasthenia gravis. What is a gold standard test? It's about how they frame it. So I want you to remember that the most sensitive test for diagnosis of myasthenia gravis is going to be single fiber electromyography. Good. Single fiber electromyography. And most specific is going to be finding anti-acetylcholine receptor antibody. So if examiner wants to ask you more precise question, he may ask you what is most sensitive and what is most specific. Being specific, acetylcholine receptor antibody assay can be considered as gold standard. Muscle biopsy का कोई role नहीं है. Electromyography, if I'm doing, I would prefer to do it single fiber. And this one, nerve conduction study, has nothing to do with the myasthenic gravis. Nerve conduction study is useful for identifying demyelination and axonal injury. So this is useful for diagnosis of the GB syndrome, not for myasthenia gravis. Myasthenia gravis is a disease of neuromuscular junction. So we will stick to option C, anti-acetylcholine receptor antibody test. Next, which type of stroke typically presents with sudden onset weakness or numbness of face, arm, or leg on one side of the body? Bit of a strange question, to be very frank, but yeah, let's try to answer. Which of it likely to present, or indirectly, like you got a patient with hemiplegia. Which stroke it is more likely to be? Is it going to be ischemic, hemorrhagic, lacunar, or subarachnoid? So remember, when we have stroke can be ischemic or hemorrhagic. Ischemic or hemorrhagic. Hemorrhagic accounts for less than 15% of all cases of strokes. Ischemic account for more than 85% of cases of stroke. So overall, ischemic stroke is more common. Within this 85%, 50 to 55% of cases are thrombotic stroke, where a clot gets formed inside the blood vessels of the brain, and 30 to 35% cases are going to be embolic or thromboembolic or cardioembolic, you can call it as, like in patients with atrial fibrillation, clot formed in left atrium embolizes to the brain. So overall, this is the stats of the stroke. Subarachnoid hemorrhage, yes, is technically considered as stroke, falls under hemorrhagic stroke. Majority of them present with altered sensorium and severe headache rather than hemiplegia. Most common cause for subarachnoid hemorrhage is rupture of berry aneurysms. Lacunar stroke is a term used for development of tiny, small infarcts. These patients don't present with sudden onset weakness, because lacunae means small cavity like. That's what the meaning of lacunae means. So if I have, let us say this is the brain that we are looking at, the lacunar infarct, first time a small infarct happened, another small infarct, another small infarct, another small infarct. So over time, infarcts accumulate, and then someday patient will have a presentation with weakness or other manifestations. But it is going to be a stepwise progression or step ladder progression. Symptoms keep adding, and patient comes to the hospital. It's not going to be sudden onset. So lacunar strokes are unlikely to be sudden onset. So I have to choose primarily between ischemic and hemorrhagic, and because ischemic is more likely, I would consider that this patient more likely had a ischemic stroke rather than hemorrhagic. Can I be confident to say that this is ischemic only? No. I have to do a CT non-contrast to decide whether it is ischemic or hemorrhagic. But probability wise, yes, it is more likely to be ischemic. Next, Huntington disease is an inherited autosomal dominant disorder. It is characterized by, I think all of you would have answered this. We know that Huntington disease is also called as Huntington's chorea. So their patients present with choreiform movements, and there is a risk for dementia. Intention tremor and ataxia is a sign of cerebellar damage, cerebellar dysfunction. Rigidity and bradykinesia is feature of Parkinson's disease. Parkinson disease or Parkinson plus syndromes. Similarly, tremor and postural instability is pointed towards Parkinson disease or Parkinson plus syndromes. So we will stick to option A. Now, what is the primary neurotransmitter involved in Parkinson disease? Again, a pretty simple question. That's going to be dopamine. Acetylcholine is a primary neurotransmitter which is involved in Alzheimer's disease. In Alzheimer's disease, acetylcholine is the primary neurotransmitter which is affected. So that's why in Alzheimer's disease, we try to increase the acetylcholine by blocking the acetylcholine esterase enzyme so that I will have more acetylcholine. That's why drug of choice for Alzheimer's is donepezil. In Parkinson disease, we will try to increase the dopamine by giving dopamine agonist or a dopamine degradation blocker. Dopamine gets broken down to inactive products by catechol-O-methyl transferase or monoamine oxidase B. So we tend to block this monoamine oxidase B with rasagiline, salicyline, or catechol-amine O-methyl transferase by the tolcapone, entacapone. So dopamine is the main problem in Parkinson disease. Next, which condition is characterized by, okay, I feel most of the questions that were formed in the test were pretty simple and pretty straightforward, and I hope that all of you will get a very good score. Let us use that as a boost, mental boost to prepare the next test. I hope it will be more difficult and you should be able to test yourself. Which condition is characterized by recurrent seizures? Of course, any of these conditions listed here can cause seizures, but we will call it as epilepsy when more than or equal to 2 episodes of seizures occur, more than or equal to 2 episodes of seizures with no identifiable cause. Then we will call this as epilepsy. So epilepsy is where seizure is not for the first time. At least 2 episodes have happened and we have not been able to find a cause. If I find that there is a tumor in the brain, I will not call it as epilepsy. We will simply call it as seizures. If there is infection in the brain, it is just seizure, not epilepsy. If there is a stroke and that is causing seizures, it is just seizure, not epilepsy. Epilepsy is where you have at least 2 episodes and you don't have an identifiable cause. So option C is where I am likely to get, because epilepsy is a recurrent seizure condition. If meningitis has caused seizures, I may not have recurrence. Migraine is not likely to cause seizure. Stroke can cause seizure, but recurrence risk is low. So we'll stick to option C. Okay, this is kind of a physiology question. I don't think we need to be addressing it. Your vision is because of the optic nerve. Eyeball movement is because of the oculomotor nerve. So if anyone got confused, you know, movement of eyeballs is by oculomotor nerve. A patient present with sudden onset slurred speech and facial droop. Which artery is most likely involved? Sudden onset slurred speech and facial droop. Which artery is most likely involved? So can anybody answer this? The area, see, if there is slurring of the speech and the facial droop, then the area of the brain regulating the facial control and the speech should be affected. So what is the blood supply for the motor area where face is represented? It's coming from the middle cerebral artery. So just to recreate our motor homunculus, this is our motor homunculus, and we know that in the superomedial region of the brain we have representation for the upper limb. So the neurons for the lower limbs, for the neurons for the regulation of the lower limb are present here, and then this is where our hand, arm, their neurons are present. So this is going to be upper limb, and the most lateral part of this area, lateral most part of the frontal lobe where motor homunculus is there, we have the representation of neurons for the face. And blood supply for this medial part of the brain. The superomedial part of the brain where lower limb is represented is coming from the anterior cerebral artery. And where the face and upper limb is represented, blood supply for this is coming from middle cerebral artery. So when I cut off the blood supply to face, I can have the UMN type of facial droop. I can have even slurring of speech. So middle cerebral artery explains the development of facial weakness of UMN types. Bell's palsy is clearly because of the facial nerve defect, which can happen because of the viral infections and other causes. Many times it remains idiopathic. So anterior cerebral artery is supplying. So point to remember, anterior cerebral artery is supplying the blood to this area, and middle cerebral artery is supplying the blood to this part of the brain where upper limb and face is represented. So if upper limb and face become more weak, it's MCA to be blamed. Lower limb becomes predominantly weak, it is ACA to be blamed. Which of the following is the typical feature of amyotrophic lateral sclerosis or ALS? Resting tremor, hemibalismus, muscle atrophy and weakness, coriform movement. What is ALS? Amyotrophic lateral sclerosis is an MND, motor neuron disease. It's a MND or motor neuron disease. What happens in motor neuron disease? Selectively, motor neurons get damaged. Now, what do I mean by that? There is no damage to the sensory neurons, no damage to autonomic neurons, no damage to any other higher mental function neurons. Only motor neurons get damaged. Then we will call it as motor neuron disease. Another classical example of motor neuron disease is poliomyelitis. In poliomyelitis, poliovirus selectively affects the anterior horn cells, which are cell bodies of lower motor neuron, then only lower motor neurons die. Another example is lathyrism, neurolathyrism, where beta-oxalylalanine or BOA toxin selectively affects the upper motor neurons, so only upper motor neurons are dysfunctional. ALS is a mixed motor neuron disease where the death of both UMNs and elements happen. UMNs and elements happen. So a lot of muscles will become atrophied because their elements are lost. A lot of muscles will become spastic because their UMNs are lost. So we'll have a mixture of LMN and UMN lost or LMN and UMN affected group of muscles. Whether LMN is affected or UMN is affected, the muscle will be weak for sure. So patient will become progressively weak in the limbs. He will also develop bulbar or pseudomulbar palsy. So they will have difficulty swallowing, difficulty speaking, right? And there is increased risk of aspiration. The 3Ds of dysphonia, dysarthria, dysphagia will come into picture, and there is a high risk of mortality. So among the given options, the only thing that can describe ALS is option C, muscle atrophy and weakness. Resting tremor, Parkinson disease. Hemibalismus, subthalamic nucleus lesion. Coriform movements, caudate nucleus lesion. So only condition that can explain here ALS is muscle atrophy and weakness. Okay, next. A 65-year-old man presents with 6 months history of progressive difficulty swallowing and chewing. Is also complaints of drooping of both eyelids that worsen throughout the day. On examination, you notice fatigable weakness of the bulbar muscles and ptosis. Which following test would be specific test for diagnosis? So from the story, you recognize that this is talking about myasthenia gravis. Now they are asking which one of them is specific. Single fiber electromyography is most sensitive, is not most specific. It is most sensitive. Specific nahi hai, sensitive hai. Most specific is acetylcholine receptor antibody assay. This will be the most specific. So we will stick to option C as our answer. Next, a 55-year-old woman with resting tremor in her right hand that started 2 years ago. Krishna Arhan, absolutely right. A 55-year-old woman with a resting tremor in her right hand that started 2 years ago. She also notices stiffnesses in her right arm and leg, which becomes worse when she tries to move. On examination, she has a resting tremor, cogwheel rigidity, and bradykinesia. Okay, I think from the question you already know what is this talking about. There are cardinal manifestations of Parkinson's disease already present. She has resting tremor. She has stiffness, which is nothing but rigidity, which they have also mentioned that there is cogwheel type of rigidity, and there is bradykinesia. So all the cardinal manifestations are there. So we'll choose this as Parkinson's disease. So here in this question, the diagnosis is Parkinson's disease. Next one. A 40-year-old woman presents with sudden onset double vision and drooping of her left eyelid that worsens throughout the day. She also reports weakness in her arms and legs, particularly after prolonged activity. On examination, she has ptosis and weakness of eye movements on sustained upward gaze. Which of the following antibody is least likely in this patient? Which antibody is least likely? Well, again, this story is about the myasthenia gravis. So when it comes to myasthenia gravis, in myasthenia gravis, multiple antibodies are seen. And why antibody profile is important? So in myasthenia gravis patients, the most common antibody that we encounter is anti-acetylcholine receptor antibody. And if you have myasthenia gravis, because of this antibody positivity, such myasthenia gravis will be called as seropositive myasthenia gravis. The second most common antibody is going to be anti-muscle specific kinase antibody or anti-musk antibody. This anti-musk antibody, if it is positive, see, in myasthenia gravis, we just rapidly or randomly do not ask for a blanket testing of all antibodies. We start with anti-acetylcholine receptor antibody. Agar ye positive hai, to seropositive myasthenia gravis. If it is negative, then we do next one, that is anti-musk. And if that is positive, we are going to call it as seronegative myasthenia gravis. Seronegative myasthenia gravis. If that is also positive, relatively rare, less common antibody that is there, we will do that is anti-lipoprotein 4 receptor antibody. Anti-lipoprotein 4 receptor antibody. Just give me a second. Anti-lipoprotein 4 receptor antibodies. So among the antibodies that we know to exist currently, this is least likely to be seen. And if that is positive, we will call these patients as having double negative myasthenia gravis. Why am I calling it as double negative? Because the most common and the second most common, the two antibodies are negative. The two common are negative. That's why it's called as double negative. Now, what is the significance or importance of doing these antibodies? When we are treating myasthenia gravis, there comes the question of role of thymectomy. Now, there is a belief or the evidence to say that the antigen for this antibody is actually there in the myoepithelial cells of thymus gland. So if I remove thymus gland, no antigen present, so no antibody formation, the disease can resolve. So thymectomy can be curative in a good number of patients with anti-acetylcholine receptor antibody. But the antigen for this anti-musk is not there in the thymus. The antigen for anti-LP4R is not there in the thymus. So for these patients, thymectomy is not useful. So if I know the antibody status, I can decide for whom thymectomy is useful and for whom thymectomy is not useful. Thymectomy is not useful for this patient because these patients antigen is not in the thymus gland. But for these patients, thymectomy is highly useful. If the age of the individual is less than 50 years, we can go ahead with thymectomy. Thymectomy is useful for seropositive or anti-acetylcholine receptor antibody positive myasthenia gravis. So we have 3 antibodies. We should remember all of them. Now coming to this question, anti-musk antibody, it is seen. Yes, this is the second most common antibody in myasthenia gravis. Anti-LP4 is present, not very common. It's the least common antibody in myasthenia gravis, but it is seen. It is least common antibody in myasthenia gravis. and anti-acetylcholine receptor antibody is the most common antibody in myasthenia gravis. The AMA anti-mitochondrial antibody is not seen in myasthenia gravis. So that by default becomes our answer, right? So that's it on this test. We have covered all the questions that were covered in the test. If you want me to build the next test based on any particular systems, giving more, I didn't get your question, Chaitanya. Okay. So in the next test, if you want me to address any particular system or particular chapter more, then I will tell the team to prepare more questions on that so that in the discussion we can address them. Some of you were requesting to include ABGs. For November, yeah, we are starting the INI CET PYQ soon. I think it's already started. Vivek sir was covering the Physio INI CET questions. So as per the schedule, even I will be covering all the medicine INI CET PYQs. Yep. Okay, so let me know the topics that you want me to cover specifically so that I can bring in some questions from that topic and we will have more detailed discussion on those topics. One of the requests I've received so far multiple times is ABG, so I will make sure that we have few questions on the ABG in the next test. Any other topic, let me know in the Telegram. I will definitely address them in the next test. The next discussion is on 13th of this month. Okay, guys, see you soon. Study well and stay focused. And now onward, just concentrate on only important topics, important questions, and the important sources. No need to loiter here and there. But sure, we will address arrhythmias, MI, and AV block related questions in the next test. Okay, all the best, guys. Study well. See you soon in the next test and discussion series. Till then, have a good time. Bye.